tolerant phase, which we now refer to as e-antigen positive chronic infection. But I'm going to show you some data where we show that this disease phase is not a benign disease phase with lack of disease progression. I'm going to show you this concept of clonal hepatocyte expansion and integration. I'm going to show you the presence of virus-specific T-cell responses which are preserved and therefore may benefit, or groups telling us that these groups are immunologically very similar. If we then look at the CD127 low PD1 positive CD8 T-cell population, this is a marker of full exhaustion of the T-cell population. And what we're able to show that as patients become older, into their 20s, 30s, 40s, 50s, their T-cells become more exhausted. And then the NIH recently published some data confirming our previous findings, published in JCI Insight, and they said that the immune cells and evidence of effector function are observed in immune tolerant and in immune active patients at similar frequencies. So you can see the field has moved on in understanding better the disease processes which are already underway in causing disease progression and progression to liver cancer. This brings me back to this concept of clonal hepatocyte expansion, and I'm going to show you here, these are patients out of my clinic as young as 15, 17, 18, already with a clonal hepatocyte expansion, which down here I'm showing you is the risk factor for the development of liver cancer. And the clonal hepatocyte expansion in this e-antigen positive chronic infection is virtually no different to what you're seeing in e-antigen positive chronic hepatitis and no different to e-antigen negative chronic hepatitis. So this clonal hepatocyte expansion, HBV integration is already present and already driving the development of liver cancer. So when we finished looking at these highly viremic patients, we then went on to study low viremic patients, and this is a paper that we published in GOT in 2021. And what we're showing you here is that if you study patients with a HBV DNA of less than 2,000, 2,000 to 20,000 in blue, and greater than 20,000 in red, we show virtually no difference at all in these patients with below or above 2,000 IU, same level of cccDNA, same levels of pregenomic RNA, but most important of all, the same levels of HBV integration. So by whole exome HBV integration, there's no difference in patients who've got an HBV of less than 2,000. Patients based on a disease phase or some historical interpretation of the disease is a mistake, because these patients are progressing their disease and are at risk of liver cancer. So what's the impact of nukes on integrated HBV DNA? I've shown you that we can suppress the virus, we can normalize liver enzymes, we can reverse fibrosis, but what can we do to integrate HBV DNA? This is an important question which was addressed in two very important studies in the last 12 months. This was published in 2022 in Clinical Infectious Diseases, and it's basically biopsy studies where this is baseline biopsy studies, this is studying the biopsy at 1 year and the biopsy again at 10 years. And these are all patients who are treated with a nuke. And what I'm showing you here is, it won't come as any surprise to you, that 1 year into treatment the HBV DNA is suppressed, 1 year into treatment intrahepatic total HBV DNA is significantly reduced, and even the cccDNA after 1 year of treatment is significantly reduced. Very much along the lines of what I was telling you earlier. But most important, and this is a new observation, that the median hepatocyte clone size has been reduced by 43% in those patients on nukes. So for the first time showing us that in patients who are treated with nuke, we can reduce integration and we can reduce clonal hepatocyte expansion. This is a similar study published by Hugh in gastric integration. The issues around resistance we don't really consider anymore. Nukes are very safe, so we don't have concerns around safety. Generic drugs are widely available, so cost is an issue. And finally, the whole discussion around lifelong treatment is also disappearing, because with the functional cure program, we expect new therapies, and we don't expect any patient that we're putting on a nuke these days will be on the drug for life. And that's another important point to get across to our patients. So these are my first set of concluding remarks before I show you some of the clinical trial data. So HBV DNA integration, clonal hepatocyte expansion, these are really important elements of hepatitis B, which are now associated with hepatic carcinogenesis and development of liver cancer. Treating patients earlier can prevent and avert the development of liver cancer, and this is really something that we need to all focus on by treating more patients and maybe capitalizing on treating patients earlier with a more functional immune response. There is a compelling case to treat patients in these early phases of the disease, and I've led on a Janssen REEF-IT study, which is the use of an siRNA in immune-tolerant patients. The data of that I hope we will be able to show you later this year at ASL. And as I said earlier, treating patients earlier, reducing the threshold of HPV DNA to treatment. At the bare minimum, you should be treating patients with a viral load of greater than 2,000, and maybe treating patients with any detectable level of HPV DNA. So moving on to the trial data, these are trial data presented at ASL, stand up here, so I won't discuss those in much detail. The inclusion criteria are shown over here. You have to have chronic hepatitis B for over 6 months. You have to have an ALT of less than twice the upper limit of normal. The HPV DNA must be suppressed on nuke, and the surface antigen must be greater than 100 IU per ml. All patients on stable nuke therapy going into the study. And straight away you will see the two arms, arm 1 and arm 2, where the 24-week reduction in proportion of patients with surface antigen loss during post-treatment follow-up. So if I show you arm 1 here, at 24 weeks, which is end of treatment, you've got 26 very strong drugs in terms of their ability. You will see that the siRNA targets the overlapping region, can silence all HPV transcripts, so that's very important. And then these are drugs which are administered subcutaneously. Phase 1 and 2 clinical trials have shown they're well tolerated and lead to substantial reductions in surface antigen. And they are designed to remove the tolerogenic proteins and inhibit variant production. So you can imagine these drugs are thought to reduce surface antigen, E antigen, and by doing that, allow the host immune response to return. So what have we seen with these drugs?
We are very much grateful that he has joined us here. I'm sure, I don't know whether this is your first time in Hyderabad. You've been here before, so you are familiar with most of them. You are familiar here. Yes. So one thing I wanted to ask you, forgive me if it's a question which most of the people might have already known. When you hear functional cure, what does that exactly mean? Is that means a partial cure, not a complete cure?
I mean, functional cure is surface antigen loss with HPV DNA, so it is beyond partial cure. It's the concept of surface antigen
It's
loss.
close to the complete cure?
Yes, it's closer to
complete cure.
Yeah, it's
and the patient is back to his routine life. And
well, if the patient loses hepatitis B surface antigen, by definition, they no longer have chronic hepatitis B. So that's why functional cure.
So thank you very much. He explained to us what the functional are. I didn't know much about the functional cure, so we know now what exactly it is. I think we should have more seminars and symposiums and discussions like this, what we have this afternoon. And I'll request our Director of Hospital, Professor Ashraf, to invite Professor Patrick Kennedy to invite him to our place as well for a special lecture. But I'm sure there's so many medics sitting over there that won't be knowing what we have discussed here today. So let them benefit from his expertise as well. And again, Professor Sadik is doing a wonderful job as he's gone outside. He's doing a wonderful job in all aspects of the gastroenterology. You might have known Dr. Sadik very well. He used to be our, what I should say, colleague there in Isra University, but for some reason he decided to go part and sit here separately and do the gastroenterology specific services here, which is a correct thing. I think soon, inshallah, he will discuss the service in a better way. Sadik sahab, आप आइए, आपकी की बात हो रही है. So I was trying to inform Patrick that Sadik used to be with us, and for some reason he left us and he came to join us as his own step in his own practice here, which is a good thing. But let me show you that we are with you, and please do come along to our place of work and let our patients come to you and let your patients come to us, so that after all, we all physicians want our patients here to be the best. This is what our physicians do is. So we are open for you anytime and whenever you ask us. I already requested Dr. Ashraf to invite Professor Patrick, not better candidate comes our place and go for an election. And thank you very much for inviting me to this seminar. This is a wonderful job that you are doing, and I'm sure you continue to do the same. Thank you very much, ladies and gentlemen.
YouTube channel तव्हां सां मुखातिब आहे ऐं असां पब्लिक हेल्थ कम्यूनिटी मेडिसन ऐं ॿिया जेके सिहत जा ऐं सोशल इशूज़ आहिनि पाकिस्तान जे अंदरि या दुनिया जे अंदरि उन ते थियल ताज़ी रिसर्च मालूमात तव्हां ताईं पहुचायूं था आसान ज़बान में। इनखे लाइक कयो, शेयर कयो ऐं सब्सक्राइब कयो ऐं कमेंट्स कयो। थैंक यू। कोलाची यूट्यूब चैनल से हम आप को खुशामदीद कहते हैं और इस चैनल पे हम पब्लिक हेल्थ कम्युनिटी मेडिसन और जो सोशल इश्यूज़ होते हैं मुल्की लेवल पे और बैनुल-अक़वामी लेवल पे वो बताने की कोशिश करते हैं और उसमें जितना भी रिसर्च और दूसरे मालूमात होती है वो हम आसान ज़बान में आप तक पहुंचाते हैं। इसको लाइक करें, शेयर करें, कमेंट्स करें। खुदा हाफ़िज़।